So everybody, really glad that you could join us at the Kokua meeting. My name's Jeanette Kojane, and I had just some short announcements that I wanted to make, and then Hope is going to introduce our two speakers from Hawaii Care Choices that we are so glad are joining us today. So we make a lot of announcements through our newsletter, so if you don't get the newsletter, that would be a thing to sign up. You could send us a text in the chat, or you can go online, but that's really the best place to find out about all the things that are going on in this space as we really work to improve care for those with serious illness. So I'll put it out there, a lot of people are doing Zoom trainings. Hope is doing a bunch of trainings with the state. We did with EUTF last week, 119 people came to do a talk on advanced care planning. So if people have ideas for any kinds of groups, let us know, because we're good at doing Zoom talk. I wanted to make people aware of a very cool conference that's coming up in June. We are doing a collaborative effort with the coalitions in Arizona and California. So these are groups that, like us, work to improve care for people with serious illness, and they invited us in, and there's gonna be presentations from people from all three states. And the emphasis of the conference really is going to be how are we improving access to palliative care in a community setting. So that's what the emphasis of the conference is, but there'll be other things around advanced care planning. And I think people have heard before that our MedQuest office, so the agency that provides Medicaid recipients with health care here in Hawaii, is very committed to offering a palliative care benefit. And they are actually, despite the pandemic, and the next step in the process is going to be a summit at the end of June. So stay tuned. MedQuest has hired an actuarial because they got a grant from a group in San Francisco. So this is real, it's moving forward, and we are really hoping that we will be the first state in the country that has a palliative care benefit for Medicaid recipients. Considering more than a quarter of people in Hawaii get their care through Medicaid, this will be a huge game changer. And then one last fun announcement connected to palliative care. I know many of you attended the Palliative Care Summit last year and have heard that there's been a lot of work going on to really look at this question of how can we boost palliative care. So I'm Kokua is really thrilled that we are part of Hui Pohala. Ray Seitz, who said she's trying to retire but failing because she is really one of the key movers and shakers behind making this happen, of looking to see as a state, how can we really be moving forward with getting more palliative care? It's not a simple issue, has a lot of different pieces, but boy, this is a really important thing that we're doing. We are actually actively looking for people who are interested in being in working groups. Hope and I and Karen Ireland are on the Palliative Care Awareness Committee. And there are also groups looking at sustainable financing, looking at data, and then clinical education. So I really hope folks will, if you're interested, you can reach out to me, you can reach out to Ray Seitz and ask more about that. I want to thank everybody who's a member of Kokua. Thank you for joining. If you haven't re-upped or haven't joined, we count on membership to keep things going. So thank you very much. You can find more information in the latest newsletter or on the website. I will now turn it over to Hope to introduce our speakers.
Nani is the community relations manager, and she's responsible for branding, messaging, educating healthcare providers, medical staff, patients, their families, and creating strategic collaborations throughout the community. And Kara is she's a community liaison of Hawaii Care Choices, and she's certified hospice and palliative sales professional by Healthcare Strategica. She holds her master's degree in nonprofit management and has worked in provider relations and community health initiatives for 20 years. Thank you both for joining us and sharing your insights from Hilo.
Thank you.
And I really wanted to say, I'm going to interrupt Hope, which is, of course, what I do all the time. You know, we have heard for many years, and of course have heard from Brenda Ho about all of the work that's going on in Hilo. So we really are, you know, we're really grateful that you guys can come and talk, because you are making things happen that other people are talking about. So thank you for coming and talking with us today.
Thank you so much. Thank you, Hope, for introducing us. I hope everybody can see us. Okay, and also, of course, Jeanette, thank you so much for being our gracious host as well to have us come here. So I'm Lani, as she said, and Kara is also joining me today. And I'm here to share some of the innovations that we found along the way. Being in healthcare for over 35 years, it's definitely been an interesting journey for sure. In fact, for some of you who may not know that we were Hospice of Hilo prior to this, we decided a few years ago to change our name to Hawaii Care Choices, and largely because once we added palliative care, we had basically outgrown our name of Hospice of Hilo. It was kind of like, you know, calling McDonald's Big Mac. You know, you just can't call them by just one item because they have so many other things on their menu. And so as a result, we went ahead and we changed our name to Hawaii Care Choices, because ultimately we're going to provide this care in Hawaii. The center of everything we do is the care, and Choices is our gift to the community, where they know that the care and the choices will be with them. And so here you have it, our Hawaii Care Choices. So let me get right onto it. There's so much to unpack in this. So we have 3 main programs, and of these programs, we have a lot going on. So our palliative, hospice, and bereavement. And because I'm not really going to touch on bereavement, I'm just going to say to everyone now that we have community support groups over Zoom every week on Tuesday at 10:30. And then we also added our children's bereavement as well. So that continues in spite of the pandemic. And as everyone knows, everyone's on Zoom now. The innovations I'd like to share, or both Kara and I, is in palliative and hospice. And it's been so exciting for us, but not without pain. So I'm letting you know that we've journeyed through the thick and thin of it. And the fact that we're here letting you know how we got here is both terrifying as well as satisfying. So I'm so glad that we're able to share it. So first of all, on the palliative side, some of our innovations was grounded in changing our palliative care model from a RN-driven model to a APRN, or provider-driven model for the reimbursement. And that seems so far to be doing good. We also collaborated with Hilo Medical Center, who with us created a palliative screening tool that automatically screened all of the patients that came into the hospital. And we'll touch on that a bit as well, on how that all came about. But it's just amazing having a screening tool like that. And then also, we're going to touch a little bit about the United Healthcare pilot program that we started to probably now it's been well over a year that we've been doing that. The innovation on the hospice side, which is a subset of our palliative program, is this very exciting CMS demonstration project, which is called SIP, Seriously Ill Population. And we'll touch on that as we collaborated with Acclivity Health. And that's going to give us access to some artificial intelligence that we did not have before, but it's really going to be a game changer. So we're looking to do that, as well as duplicate some of what we do at the hospital out in the community as well.
Okay, thank you, Lonnie. Okay, so I will be talking about our innovations in palliative care. And we have moved from a nurse-driven to a provider-driven model. And can you see the screen? Can everyone see the slideshow? Okay, perfect, thank you. And so instead of previously, we had all of our services, we had the social worker, we had the nurse going out to the home, and that was not reimbursed, right? And so now we have our APRN who is going out to the home and she is able to bill. So we have a provider-driven model. The frequency of her visitation is based upon a ranking for how ill the patient is. And so the APRN and the LCSW both bill for their visits. We are targeting a clinic location in the future so that we can have patients come to us. Also, Hawaii Medical Center will ask for consultations from our APRN. So they'll put in orders for consultations. And what you see on the screen right here is a list of all of the things that the discharge planners know to ask for a consultation. So our APRN will come into the hospital and bill for a consultation with the patients. And we also have an RN as well as a community liaison in the hospital. And they see patients as well, but specific to our APRN giving a billable consultation, this is what the discharge planners know that requires a consultation. Number one, if they're having uncontrolled pain, if they're having constipation, nausea, vomiting, depression, anxiety, secretions, poor appetite. So all of the things that are symptomatic needing palliative care that a provider could come in and do a consult for. Additionally, she'll do code status, living will, pulse, as well as triggering events. So someone who just got a trach or maybe had an amputation, she'll do a consultation for those as well. So she is coming very frequently to the hospital to do consultations for us.
What was great about what Kara just added there is that we are not limited with regard to the diagnosis, where we would normally within our palliative care program be focusing on 4 main diagnoses such as COPD, CHF, kidney failure, and cancer. When the discharge planners set up an order for a consultation, they can go well beyond that. And that's what the beauty of that innovation is. Back to you, Kara.
Okay, and additionally, our team is working on a transitional plan of care. Previously, what would happen is we have such a good team. We have such a good palliative care team. We call that cuckoo care. And what would happen is that our patients would get so attached to our APRN, to our RN actually, and to our social worker that they didn't want to transition over to hospice. And so now we have that as part of we'll have a plan of care, and then we have a transitional plan of care. So basically we're putting the power, choice, self-determination in the hands of the patient, that when they're ready, they have the empowerment to transition over to hospice. Okay, and our team continually encourages them, not only, do they form a great relationship with our team, but they're encouraging them to have that empowerment and recognize with their transitional plan of care when is a good time to transition. And so now as one of their metrics, we're looking at monthly with the team meetings, how many transitions happened this month, and we're finding those transitions are going up based on the emphasis of the transitional plan of care, which the benefit of that is that we're catching people further upstream, which is increasing their length of stay, right? We're getting people from palliative care in sooner to hospice care, which helps us to increase our length of stay, but also increases the benefits that the patients get from longer time in hospice.
So I went and I interviewed a family. The patient was in Kupu care, and previous, when we would have people in Kupu care, they wouldn't want to leave. They actually preferred to pass in that program. However, now with the way the Kupu care model is, the intention as soon as the patient comes into palliative care is we're already starting the advanced health care directive and really talking about, you know, the higher level of care that they will receive in hospice care so that we can empower them with the information and they can make that decision to move over when they're ready. And because I'm very interested in the end user experience, it was wonderful to hear the patient say she was ready to go to hospice care, and she decided that between her and her husband, who is her caregiver, that she was ready and she was happy about it. So the difference is really our approach and our perspective as we have the patient admitted into palliative care to begin with.
Another fantastic innovation that we have just recently is in July 1st of 2020, we implemented a partnership with Hilo Medical Center. And so they have an automatic screening tool that every patient that's admitted into HMC goes through the screening. And based on that screening, they will get a consultation or a visit from our RN and our community liaison. And so every morning, every single morning, we have an RN and we have a community liaison who are full-time stationed at the hospital. And they meet with the discharge planners and they have a little talk story session on all the patients they have referrals for that are triggered by this automatic screening tool. And then our RN and our community liaison go in and meet with all of those patients every single day to determine what their goals of care are. And from there can determine if they're good candidates for palliative care or hospice. Our visits are documented in the Hilo Medical Center EMR system. Okay, and so we work now, we're just bonded at the hip, I would say, with the discharge planners in that their discharge planning is integral to our visits with, I would say, you know, most of the patients in the hospital do trigger this tool. When they do accept our services, then it's documented into the EMR system. It's flagged on their chart as a special indicator. So should they be readmitted in the future, it's flagged up there that they are a current palliative care patient. So this is fantastic. And I'm just going to show you that next slide is our screening tool that Lonnie will address.
Yeah, so at Hilo Medical Center, what was really the impetus of it all is, of course, we're trying to figure out how we can help them with their mortality rate with regard to how many people are dying at the hospital. They would definitely want to move them onto some kind of program before that happens, and they want a warm and safe discharge. Well, they went to get this tool from CAPC, and then they customized it particularly for us. And so if you look at the bottom where it says scoring guidelines, this score here has everything to do with what action is taken next. So on the total score number 3, consider consult, that's where the discharge planners take a closer look and see if this patient would be one that's good for us, or if in fact they need to order a consult with our APRN. And so that has been a wonderful way to really look to make sure that nobody falls through the gaps. And then of course, if they score 4, that means that that person is automatically going to come to our RN in the hospital as well as our community liaison. So what's really great about this tool is that previous to this, the hospitalists would have their own opinions involved in whether or not, oh, I don't know if this, I don't want to misdiagnose this. And so as a result, there were so many patients that required palliative care, if not hospice care, and did not receive it. And so now with this tool, we're able to get pretty much everybody that was there. So let's just say we might have gotten previous maybe 10 referrals in a 10-day period. That's like one a day, where now we can get anywhere from 20 to 30 referrals in a 10-day period. So it's amazing how many more people we're able to help just because of this screening tool.
And right here, we'll demonstrate Lonnie's statement there. We have the outcomes that were given to us by Hilo Medical Center. And so it's sort of, hard to read on the screen there, and I'll just read it for you. The orange, the bright orange there is a positive screen. So July to November of 2020, we did 504 positive screens, okay? Meaning that we came in and spoke with the patient, or that the patients were screened and that it indicated that they needed the services, okay? And then the gray is the patient ordered consult. So before January to June, so before we implemented the tool, there were only 60 patient ordered consults. After July, when we initiated that, 510 ordered consults. So 60 to 510 is a huge difference there. And then with consulted patients at HMC, so prior to then, there were 218, and after July, 454 consulted patients. How many enrolled in Kupukera Hospice? 139 before and 108 after. And, I find that number there actually a little bit confusing, considering that we had so many referrals. So maybe we can have someone re-examine those numbers. But I was in the hospital for several months working with the community liaison that's currently stationed there. And I can tell you that it was an incredible hustle going from room to room to room, 8 hours every day, consulting with patients that were ordered a consult, and many of them coming into palliative care as well as hospice care, as well as coming over to our inpatient facility. And so what I'm doing now in the community, I was working in the hospital to see how that was working so that I could go replicate that in the community. And what I'm doing now is going to places like, I've already spoke with Hawaii Pacific Oncology. I'm currently speaking with the cardiology clinic. I have a meeting with the vascular clinic coming up. I'll be meeting with one of the providers with Hui Malama very soon. And I've been meeting with providers of Big Island Healthcare. And what I'm doing is approaching them and saying, we've got this fantastic partnership with Hilo Medical Center, right? We're giving them the premier treatment that they don't have to spend the time looking through their patients for who to refer. Like Lonnie was saying, the hospitalists don't have to take that time determining. We can bring those same curated services that we're giving to Hilo Medical Center to you. I can drop in weekly and consult on all of your patients, which patients are taking up, the 10 most, which are the 10 patients that you see maybe in the emergency center, in the emergency room by next week, or which of the 10 patients that are calling your answering service. I can send a secure message to our admissions team, who then can initiate a medical records review if needed, and I can tell the provider, well, during a medical records review, we'll let you know in 24 hours if this patient is appropriate for hospice. And we also can bring people in through palliative care. So the providers are very excited about this partnership. I'm also offering to have the hospice talk on behalf of the provider. So what happens is, we had someone that the provider never would have thought that that was a hospice patient, but because I said, who would you expect to be in the ER, by this time next week? And we looked through those records and we determined that they were hospice appropriate. And then I gave the provider some tips on things to say. She said, minimal things. And then I called the patient and explained services, and we did enroll them into hospice. So it's a great new innovation. Rather than doing a training and expecting that they'll send referrals back to us, but coming in with this new partnership weekly, the same way that we're doing in the hospital with meeting with the discharge planners, we are now meeting with the providers and referral specialists to take all of the patients that they may not have considered previously who would really benefit from our services.
Oh, Kara, can we go back to the slide with our Kupu team?
And did we have, oh yeah.
I just wanted to show you that this is our Kupu Care team. So we have our RN, Jason, and then we have a coordinator, which is right there in the middle next to Anne. And so that was Erica. And then we have our APRN, Haley. And so we have a team that's specifically for palliative care. And what happens is that this dynamic team is able to really surround the patient and the families with a lot of support. So I just wanted to let you know that there is a interdisciplinary team that needs to be assigned for palliative care as well. It's a separate team from our hospice team. Thank you, Kara.
Sure. Okay, and so just, the bottom bullet on here is very important, that they do not need to know who's eligible for hospice, even or palliative care, because what we have found in doing a lot of provider education is that can be confusing, right? There's no crystal ball. And so a lot of times, providers are hesitant or maybe hesitant to decide that someone is appropriate for hospice care. So when we're coming in and asking who are the patients that you see are at highest risk, and then we're examining the records, we're finding we're getting more referrals that way and able to help more people. So the concierge services are very tailored to the community providers. And so what I'm doing to do that is all of the referrals that I collected that day, in addition to referrals that come in after I leave, I research those before I go back next week. And when I go in to speak with the providers, I give them a complete update on all their referrals. Of course, they're getting updates from our admissions department, but I'm giving them personally. I'm letting them know that one of their patients that they were so excited about refused our services because of such and such right away. And then they call the patient and talk with them again, and then we give them another call. So we're doing a real hand holding with the providers in that they know exactly what's happening when I come back. In order to be able to do that, there needs to be a lot of efficient processes that are set up. And we have an incredible team over here that is setting up such efficient processes. We've got a secure messaging system that right there on the spot, like I was saying, I can send a secure message to our team who then alerts our medical director or APRN for a medical records review. We do that very quickly. We can do same day admissions once that medical review is finished. So when I'm speaking on the phone to someone and they say, yes, I think I'd like services, I say, I can have a team come out and speak with you and your wife today, right? And so then we also, so that's what I was just saying. So you have to have all your efficient processes set up, which we have set up. And we've been working very hard to have everything set up and ready to go report to the providers on the dime of what's been happening with all the referrals. So I actually bring a laptop into the meeting as well. I look them up the day before, but they may have a question about a patient I hadn't looked up, and I can pull open the laptop and see right there what's happening from our team in real time with the patients.
Now I have a question from the audience.
Sure, thank you.
So Ray is asking, what happens to the 346 who were not enrolled? Are they still billed? Are you still billing for the consult?
I'm sorry, the 346 that have not been what?
Enrolled.
Enrolled. Okay, so there's two parts to that answer. Number one is that the word consult, that goes for our community liaison and our nurse going into, so when they're saying consult, they're speaking of a consultation provided by anyone, not inclusive to our APRN who is billing, right? And so those consults those are our employees, the nurse and the community liaison who are on staff and they're not billing. They're going in. Our APRN just recently joined the team. That's a new provider-driven model that we've just launched. And so she just started with her consults. So yes, she is billing for those consults regardless of enrollment, because as Lonnie was stating, sometimes they fall outside of the parameters of our palliative care program, but she can consult on palliative care in the hospital, regardless of whether or not it meets one of our insurer requirements. Did that answer that?
I believe so.
Okay.
That's great.
Actually, I did have a question though. What happened to those of the 456 that were screened and that your staff saw? 108 were enrolled. What happened to the other 346?
So there are many things that happen where someone in the hospital doesn't come into the program. And a lot of what was happening back during that time is that they're not screened on the exact qualifiers that our insured programs paid for, that our programs, so we have to have CHF with an EF of less than 50, right? The qualifiers for our programs, or COPD oxygen dependent. So that screening tool will flag people on certain qualifiers that aren't necessarily our qualifiers for our program. And so we'll go in and speak with them, and they may not qualify for our program, but they got a consultation or they had a talk with our RN and our liaison that should their illness progress, they would want to come on our program. So we, are equipped with flyers, with business cards. So we may not be getting immediate enrollments that month, but they may be enrolling as their disease progresses. Then you also have people, there are some people that just don't want someone coming to the home, right? For one reason or another. So it's free will. It does seem like a lot, but a lot of that was due to the screening tool not necessarily sticking right to what our program qualifiers are, which is fantastic because we get to really outreach in the hospital to everyone. Right. And a lot of times people will say, oh, my husband has this, or my auntie, can I give her the information, type of thing.
There's other programs that people are also signing up for. Some may decide that they want home health. Others may be going to a long-term care facility. There's many other options that they are being provided. But ultimately, choice is the top line. So if people choose that it's not time for them, then they won't come into the program at that time. But what we're really watching for is trends, particularly those that keep coming back into the hospital. And then we really want to get on them to help them as much as possible so we can avoid the re-entry back into the hospital as much as possible.
And then so I wanted to give just a little information on how it is that I speak with the community providers, and that is through questioning and active listening. I go in and speak with the providers, the referral specialists, as well as the patients by asking questions, right? Who will be back at the hospital by the end of the week? How does that impact you? I remember speaking with Dr. Fishberg, actually, who is here today, and he was saying that that's one of the main questions that he uses too, to speak with doctors for them to start thinking of potential hospice patients. And there's other questions in there of who's calling your answering service. How does that impact you? So a question followed by a probing question gets whoever you are speaking with interested in giving you their pain points. Once you have their pain points, then it is very easy to address how we can solve those. But had I come straight into these provider offices or the clinics saying, I can help you with your patients, I probably would get a door slammed on my face. So it's just very important, in sales as well as palliative care and hospice sales, to go in with questions, finding out what people need. I do that with the referral specialists as well. What difficulties are you having referring to us? And it takes a tough backbone to do that, because I do get difficulties. And then I have to bring those back to the team, and we have to solve those right away. And then I go back to the referral specialist and say, we solved it. I can't imagine how difficult that was happening, and we solved it. What difficulties are you having today? And by continuing to do that, I actually did that with one referral specialist for 2 months before she gave me the time to sit down. And then she sat down and said, can you go over with me again all about your programs? And so I went over all about the programs, and I said, I'll come back next week. Have a list for me of the top 10, top 5 people who are calling your call lines. And now that you know the programs, I came back the next week, she had 5 referrals for me. But it was just my persistence in asking questions and then asking probing questions. And additionally, that's the way that we have the hospice talk, right? In that, calling the patient, we never call the patient and say, we have a great program for you. It's called hospice, right? We call the patient and, what has the doctor told you about your treatment? I've been speaking with your doctor. For many of the patients we were going into the hospital, same thing. What is the hospitalist? What has your doctor told you? I want to hear what the doctor has said. What kind of treatment options are you pursuing? Who cares for you at home? How is your spouse holding up? Once I determine the pain points, then I can address those pain points with a solution. But people don't want to hear a solution until you've heard their pain points. And so that's how, seamlessly we're working with the referral specialist providers and the patients. It's just by asking questions and more questions. And then integral to that process is we have a warm handoff. So let's say that someone in the hospital, they discuss their pain points. We hear their pain points and validate that with empathy, and then we move forward to a solution to their problem with our program. They're much more interested than if we're in a rush and walk in and talk about the program. And so then they say, yes, I want to be a part of this program. I want your palliative care to come out to my home. We have these beautiful flyers that Lonnie designed that say follow-up appointments. And we write their name on the top, and we show them pictures of our team, and it says on there, someone named Erica will be calling you. They take that home with them from the hospital. We also do this is the community flyer. We give these to the providers so that there's a warm handoff when our admissions person calls. It's not out of the blue, because it would be out of the blue if we hadn't prepped them for that. Even if we speak to them about the program in the hospital, when they get the call from the admissions person, do you know how many people spoke with them in the hospital? They can't remember. They have no idea. And they may even hang up from the minute someone calls. Just having this follow-up appointment notice as a warm handoff has made a big difference in our admissions being a lot more successful. This is who you spoke with. Erica will be calling. This is your team. And then in addition to that, right next to it, we've got a flyer here that we give to the community providers that, when we first were doing this, we were talking to the providers about, this is what the programs do for your patients. We found much more success in talking to the providers about, here's what we can do to help your practice, right? And so that's the flyer that we give to the community providers. We do a 15, 20-minute Zoom call. And what do we do on that Zoom call? We ask questions. We ask questions, we hear the pain points, and then we address it. Okay. Now we're going to shift gears and talk about predictive analytics. This is incredibly innovative. So the innovations we've talked about previous to this have been the APRN-driven model, APRN consults in the hospital, the screening tool, and then the screening with community providers without the tool, but just with the staff going in. Now we'll talk about predictive analytics. This is very exciting. This is like the new frontier, right, of healthcare. And we're so excited, thanks to the leadership of our amazing executive director, Brenda, that she's got us on board as, one of the primary launching organizations that's doing this. We're working with Acclivity with their C3 database, right, which sounds very high tech, and it's the Compassionate Care Candidate. And what that database does is it uses claims data, right? So all the organization has to do is provide access to their claims, right? And then it analyzes that claims data to produce a list of patients that most likely are eligible for hospice and also palliative care. And you can see the bulleted list there of all the different parameters that it uses to determine if they're hospice appropriate. So of course, age, PPS is the Palliative Performance Scale. And we'll go into that a little bit later. Frailty, how do they determine frailty from claims data? Well, they do that from DME requests, right? The risk factor, so that is the amount of hospital visits. Someone who's had 11 visits this year would have a risk factor of 11. The Ontario Mortality Score, they actually bought the rights to be able to use the Ontario Mortality Score in this database. That is the score that Johns Hopkins is very well known for. They also do the probability of admission and readmission back into the hospital based on all the claims data, past trends, the chronic conditions count, a coordination risk. So what is coordination risk? That is patients who do not have a primary care provider or who have had fragmented care, and their probability to expire in 3 months, 6 months, or a year. So basically, this data is uploaded and they spit out a database, names of all of the patients that most likely are ready for hospice care or ready for palliative care based on all of this data. They have 4 million patients that are a part of their database right now. And so they can compare life expectancy. They can produce a pie chart that will show that your patient who has X, Y, and Z compared to our other 4 million patients who have those or had those same risk factors that expired within 3 months or 6 months. So it is amazing database that now we have paid to be a part of this database so that our, partners, physicians, hospitals, whoever can have free access to that database because we are paying for it. Now, once they are on the database, they can choose to either share the data with us, and if they do that, then we need to strike a BAA with them. And in sharing the data with us, we can save so much time for them. Can you imagine? I'm coming into these providers' offices, and every day they're having to think of all these patients who may do this or that, or every week. Now I come in with a list of 20 patients and say, these are the patients that, based on predictive analytics, will be back in the hospital, that are going to expire, that are ready for palliative care. We've actually had our team already analyze these records, and these 5 are appropriate for hospice care today, right? This will reduce your hospitalizations and rehospitalizations. This will take, our providers over here are overwhelmed. They would love to take on new patients rather than continue to serve patients with the frequency and the urgency that are tying up the practice, and love to be able to hand those off to us who are the experts at handling that. And so it's an amazing tool. We have already spoken with Hilo Medical Center. We have spoken with several clinics. We've spoken with long-term care. We've spoken with several organizations who are interested in partnering with us. And the benefit to them is this is proactive services prior to hospitalization. So let's say that they don't want to do a partnership with us and they just want to keep their data. That's fine. They can keep the data and use it for free. And they have a list of all of their patients that they might want to call and say, I'm concerned about your condition. I'd like for you to come in. Or they can call and say, how are you doing? How are you doing with your activities of daily living? How are things going for you? How about you come in for another visit? How many offices or providers have the time to be able to comb through charts like that? We can provide that for them, whether or not they partner with us. So it's very exciting new predictive analytics that is going to transform the way that we work with our community providers. It's basically the screening tool, you know, similar to the screening tool that we're using with HMC that we can bring into everyone. There, and Lonnie will talk to you about this slide about our Kokua Care Transitions program that is also using the Predictive Analytics database, Acclivity, the Acclivity. And I believe that Navi, I don't know if they're on the call, that they're also using Acclivity.
They are too. Thank you so much, Kara. So on our seriously ill population that we will be addressing, we will be going under the name of Kokua Care Transitions Practice. So we'll actually have a practice that we will be partnering with different practices and providers within the East Hawaii region. And what's great about that, as Kara just explained, is that we're able to come in and help the providers with their patient list at no additional charge to them, but also we're able to get additional referrals from CMS directly that they are picking up from their claims data and determining that this person is definitely chronic or seriously ill, is receiving fragmented services, meaning they probably don't have a medical home and they need to be stabilized. We would be the platform in which to stabilize them with the help of this Acclivity Health technology. And then once they're stabilized, for the partners that we are signed with, we would go ahead and refer these new patients to them so that they can continue to give them long-term care as well. So the choices would be, when CMS sends us a patient, we would go ahead and stabilize them and then determine whether they need to find a medical home or in fact they are ready for hospice care. We would determine that at that point. And so the partnership is definitely a game changer because we're not just waiting around for providers to send us referrals. We're in fact referring people to them. So we're quite excited about how this is going to really change the way that we provide care to our patients, because we can have this proactive model in which we are providing care when somebody needs it and when they need it the most, versus an incident or event happens and then they have to go to the emergency room. We can actually be ahead of the game and again, get people the help that they need further upstream than waiting for them to keep going to the emergency room and having a difficult time. So we're really looking forward to boosting the quality of life for our community using the Acclivity platform and being part of CMS's demonstration project with the SIP project, the seriously ill population.
Yeah, and I think what's so exciting about that is that CMS identifies the patients. They're working with Acclivity, and then they call the patients and tell them that they would like them to speak with us about our program. So we're just getting the patients right from CMS based on the tool that Acclivity is using. So it's fantastic. And as Lonnie was saying, they may go to providers, other providers for a medical home, or they may stay with us for a medical home if they're hospice appropriate. Right? So we really can identify people very upstream, just like she's saying. So in addition to that, we've got several new innovations that we've been doing here. One is our UHC pilot. We're very excited about that. And that is palliative care with wraparound services included that UHC is reimbursing us for, that is paying for. So that includes the whole team of palliative care, regular visits from our RN, medication management, patient-centered goals of care, education, clinical reports to the PCP. We'll go to the primary care providers with the patient to explain things if necessary, social work care coordination. So this really is the wave of the future with the SIP and then UHC pilot, is to have these insurance companies really recognizing the value of palliative care and paying for all of the wraparound services, not just the APRN and the LCSW that we have, because we have a robust team that really impacts our patients.
You're definitely right on that. United Healthcare had that vision to, partner with us. And not only are we able to get into the homes and do the hands-on care, but it helps us sustain the program for these patients. And we can continue to do that for United Healthcare. What's nice about this is, particularly during the pandemic, so many people didn't want to go to see their primary care physician or go to the hospital or anywhere they thought that had COVID. And so it really changed the way that people had access or wanted access to their medical care. And as a result, a pilot like this really stepped forward, and it just showed its value, that people wanted to be seen at home. And now we just continue to keep adding more people onto our palliative care programs. But we have to say that United Healthcare, they just stepped right up and helped us sustain this program, and we're able to really provide quality wraparound services for their patients.
We also have UHA Concurrent Care, is an insurance company that pays for our palliative care. So it pays for patients who are receiving treatment as well, right? And so they get the same thing but they get our hospice services, which are weekly visits from the RN, volunteers, CNAs. So they get we have two separate teams. They get the hospice team, and they can also seek treatment. Additionally, we have supportive care, which, I'm sure all of us, are familiar with supportive care. Same thing, that they get the hospice team. So we consider that it's like hospice light with treatment. And the reason we say that is because it needs a PPS score of 60 or below. And so for that, you've got significant disease progression, and you've got regular visits from the RN, volunteers, CNAs, spiritual support, medication management, DMEs. It's 90 days only. So it's meant for patients that will likely be rolling into hospice at the end of the program, or possibly for a patient who has the declined PPS, and meets the qualifiers, maybe just got out of the hospital, needs some extra support for a temporary amount of time, then to get restabilized. But for the most part, those patients do roll into hospice with the 90-day limits. And then I'm sure, go ahead.
I was just going to say that on the supportive care program, that has been brought to us through HMSA, and it has been a very lucrative program, particularly because there's so many of their members that needed this type of higher level of care. And we we're really happy to do that. And then, of course, for HMSA, they have the Palliative Performance Scale, which was so necessary with regard to us determining whether somebody qualified in a particular palliative program or not. You can go ahead and share that, Kara, on how you use it out in the community.
I just wanted to show it because I'm sure most of us are familiar with it. But the reason I brought it up is because it's part of what I do with provider relations, is that the minute that someone is not admitted, and that's what's difficult about the HMSA program, is that a lot of providers don't understand the palliative performance scale. Not that they couldn't understand it, but they're very busy, right? And so to have so many different qualifiers for different programs is challenging. And so when someone does not qualify for the HMSA supportive care because of the PPS scale, then I will personally go out to the provider with the PPS scale or to the referral specialist and let them know why they weren't admitted into the program. And so I, bring this along and explain to them that, the ambulation needs to be reduced. They basically need to be unable to do significant, to do hobby or housework based on progression of disease, occasional assistance necessary, and their intake is normal or reduced. And there has been some confusion with, providers being so thankful when I come out because, maybe they weren't able to do their hobby or housework, but it wasn't because of the disease, right? It was because of living conditions or various factors. So again, it's that ability to go out and speak with the providers and answer all their questions and solve the problems. So that's it. So we basically went over the APRN-driven model, provider-driven model. We went over the screening at the hospitals. We went over the community consultations where we're giving them that concierge services, and Acclivity that's coming up that will introduce that screening into all of our partnerships, as well as the SIP program that's coming up where CMS will direct providers as well and catch people more upstream. So we hope that was really informational and beneficial for all of you as far as, some innovations in hospice and palliative care. And we'd love to hear any feedback. If you have some questions about anything going along or some comments or suggestions, we'd love to have a little talk story and hear what they are.
I wanted to say, wow. I just wanted to share that all the areas that are in color on our map are the service areas that we cover here in East Hawaii.
Thank you, Lonnie and Kara. Really, this is fabulous information. I think it's very useful, and it looks like that's the direction of our future. I mean, you guys are catching people upstream. It's amazing. I have a question. What happens if their insurance does not have either a supportive care benefit or a concurrent care benefit? What happens to those patients? I mean, obviously you're not screening the insurance, you're screening their what's happening with them. So how do you guys navigate with that?
Kara, do you want to answer that one?
Yes. Neither Lonnie nor I want to step on one another, right? So we're very kind to each other. There are some insurances that have an alternative program, right? Like Kaiser, right? And so if that's the case, then we cannot provide services. But for insurance, for patients whose insurance does not cover it, but does not have an alternative program, historically, we have been continuing to provide the service just because our organization cares so much about palliative care. And I think that that's the case too with a lot of the hospices. So palliative care really hasn't been reimbursed. And that's one of the issues, is how do we continue to provide this valuable service without the reimbursement? So that's why it seems so innovative to have the APRN-driven model to be able to bill, and then to do these pilots with the insurance companies so that they can see the hospitalizations go down and such, so that they can continue with the coverage. And I know that our pilot with UHC is very focused on the metrics as well, so that they can determine after. Mm-hmm.
And we have quite a few number of patients, Hope, that are on either Medicare only or Medicare Medicaid. And so as a result, that will, we will either have a co-payment if it's Medicare only, but we have so many people that are Medicare, Medicaid, and then there's no co-payment at all. So yeah.
Any other questions that you can unmute yourself and or put it in the chat. You'll notice Jeff and Alan, they both have great things to say about your program. I think this is really innovative.
Oh, great. Thank you. I thought you said they don't have great things. I thought, oh, what did they say?
No, they have great things to say about you folks.
Yeah. Oh, that's great. Thank you. Thank you.
Well,
yeah.
Do we have any more questions? I just had one more thing that I was going to share.
Yes. And let me see if I can get that back. Here we are. Okay. And then the next. So there we go.
So I just wanted to share that every month I do a talk story, a virtual talk story over Zoom. And this next month, I always do it on the 10th at 10 a.m., no matter what month it is. So it just happens that in February, it's going to be on a Saturday, but it doesn't matter. We'll still do the Zoom. And my special guest for April will be Dr. Angelo Volantis. So I'm pretty sure there's a lot of people that are familiar with his work, but I remember when I first was hired at Hawaii Care Choices, Dr. Dolan gave me his book, and apparently she had given every employee in our organization his book on having the conversation. So I'm quite excited to have him as my guest, and I invite all of you to please sign up to come to the free virtual Zoom, and it should be a really interesting talk story to have someone such as Dr. Volantis part of our community discussions. So I just wanted to share that. Thank you.
Thank you. Yeah, and I just wanted to say one last thing really quickly is that the palliative care is so important. I was reading the comments of people saying, thank you so much for sharing this valuable service. And we're very passionate about it, all of us here, and it is valuable for the community. At the same time, it does reduce hospitalizations and it does improve, symptoms. And so it is incredibly valuable and does save money and improve the metrics of the provider practices as far as hospitalizations and rehospitalizations, which increasingly through CMS will be scrutinized further and further, right? So it's an incredible service, palliative care. And we hope through these innovations that its benefit is greatly recognized in the industry so that these pilots can continue. And we feel that acclivity is a game changer. And we are happy to share any information about acclivity to any of you who may be interested in learning more about it. It is the only predictive analytics database in the nation that is working with the seriously ill population for palliative and hospice, so much so that CMS is partnering with them. So we do believe that this is the horse to get on and ride very quickly. So we're happy to share any information with you about anything, in the presentation today. So thank you.
Kara, how hard was it to get the hospitals to agree to this partnership?
I'll go ahead and take that one, Kara.
Okay, great. Go ahead.
I want you to know that it has taken years for us to really get in there and make a difference. But what happened is they were highly motivated because they wanted to improve their mortality rate within the hospital, and they couldn't do it without us. And then when COVID hit, it was very strange with regard to how people were accessing their healthcare. And so we really became quite strong partners, besides the fact that Brenda and also the CEO of the hospital are also on our board and their board together. So yeah, they're two birds of a feather kind of thing. So it just, we were able to help each other, but it does take a long time for sure.
Another question for you is, the UHC pilot, is it structured like supportive care or concurrent care? Are there major differences?
They work with our palliative team. So they work with the APRN, the RN, and the social worker, whereas concurrent and supportive work with the hospice team. So for us, it's just minor differences in how we structure it with our staffing. But it basically is very similar in that it's palliative care, symptom management while they're seeking treatment, medication, social services, very, very similar.
Is there a time limit for the United Healthcare benefit?
It is not. There is not. They can be in it unlimited, right? So from the first diagnosis of cancer, onward until the patient no longer needs that kind of service.
So that's why conversations early on in the palliative admissions is really critical with regard to transitioning the patient to hospice care eventually, so that we can be sure to provide them that higher level of care when it's time and when they choose it. So all of that is pretty much part of the model. The intention when we go in right off the bat, we're already looking at how we will be able to help them boost their quality of life immediately and then continue it through where when they need a higher level of care, they'll be able to get it because they choose it.
Some more questions in the chat for you guys. So how large is Hawaii Care Choices?
So we have 116 employees. That changed actually in just the last year since COVID happened and these other programs started to really take off. I'd say, hired 50 employees in the last 8 months. I mean, it has been a wild ride, like we're hanging on, tooth and nail as Brenda is just like taking off on the train. So yeah, we're coming into the station for sure with a lot more people. Wow.
Is the Acclivity database, is that just limited to the Big Island or certain your areas?
It is not actually. It's currently in 38 states. So there are 4 million patients.
Like, pull data from other islands?
I'm guessing here. I've never asked them that question, but I'm guessing that our data is relevant to our service area, right? And that would make sense as far as our, HIPAA agreements and things like that. Yeah.
And I think, Kara, you mentioned earlier that Lonnie designed your handouts.
She's amazing. She's amazing, isn't she?
I mean, I didn't actually design it. I mean, we have graphic people with us. It's just I'm just directing them because the koi leaves are reflective of our eternal light, which comes from the kukui oil. And somebody in the chat had asked about our icons. How did we come up with our icons for the different programs? So on Kupu Care, it is the Kupu Kupu fern, which is that hurled look up logo. And that is really about when there is a lava flow and there's total devastation. The first sign of growth comes from the Kupu Kupu fern. And so this type of resilience is something that we really want to promote and remind people that that's why we are there. is because of that. And then of course, the kukui leaf in our hospice care to represent the eternal light, that this will continue well beyond the physical life. And then of course our bereavement with the butterfly, because in bereavement it's all about the transformation, the change in which happens with the passing of a loved one. And so, you know, a lot was decided on each and every little thing. There isn't anything that we do that we just sort of throw up, you know, up on the screen and just go with it. It really has a lot to do with what the care is specifically and what we are addressing at that time. So
Alan is asking if you're getting any referrals for Big Island patients who are hospitalized here in Honolulu.
So we do get patients that are wanting to come home. So we'll get patients from Queens, but they want to come home because they want to pass at home. And they will normally go into our patient care center, Pohai Malama, as the bridge to get home. And so we've had quite a few that do that. But for the most part, all of our referrals are coming from within our service area. And I think Alan also asked about the Talk Story flyer, and I'll let him know that yes, Hope has the flyer. So if there's any of you who would like to log in to our Talk Story for next month, please let Hope know and she can send that to you as well.
So palliative care, what kind of training do you provide for your staff?
I just, you know, what is so great about palliative care is, first of all, in the community, nobody knows what that word is. I mean, nobody is even saying it. So it just cracks me up whenever I tell people, oh, well, maybe your dad is ready for palliative care. I mean, I just get the, you know, the stare, like, what is that? But yes, for the most part, our clinical staff that comes aboard is already quite trained on palliative care. But local palliative care in Hilo, that requires on-the-job training for sure. I'm just gonna leave it at that. What I tell people about palliative care is that it focuses on relief from the symptoms of serious illness. People in the community, they understand what that is, but they don't know what palliative care is, and they would probably never use that word. So trying to break down the communication barriers has really created a bridge where more and more people have come across to get that kind of care because they understand what it is.
So can we just hijack kupu care?
Yeah. And, you know, Lonnie does a lot of talk stories. She really is good with getting, she paints such beautiful pictures, like she was just saying about the kupu fern, and people really get it through her educational outreach. And then when we're in the hospital speaking with patients or in the community about palliative care, we address it through, again, questioning. You know, how are things going for you? What's your goals of care? What are your pain points? When they hit those, then we describe palliative care. But if we were to try to describe it right off the bat, it wouldn't go well. We do that with the pain points first, and then we mention kupu care.
Excellent. So another question, if a physician on the Big Island wanted to get the acclivity printout for their patients' eligibility for palliative care, how would they go about doing that? Do they just contact you?
Yes, contact us. We'd be happy to speak with them about it. Let me put the email address back up there. I'm just sorry, I'm gonna have to scroll through everything. There we go, right there. There's Lonnie's email address and there's mine, and we are happy to speak with anyone about acclivity.
Just checking the chat rooms. I don't seem to see anything else. Any other questions?
I just would like to say that we greatly appreciate this time that all of you have made to come and listen to us. But I want to remind all of you that it is quite a difficult journey to get to this far. I mean, we're just condensing it into a 40-minute presentation, but it's taken us years, absolutely years, to get where we are now, and we're still evolving and learning as we go. And I just saw that somebody sent a text or a chat message on our social workers. Yes, we have social workers. I think now we have about 8. And our sister hospice company on Oahu is Navient. We actually work with them as well, and they have picked up the Acclivity technological platform as well. So they are really going to be jamming, and I'm sure they could give a lot of information as well. They're just a fantastic company for us to work with.
Anything that you folks actually did that didn't work, and it would just save people time if they don't attempt to try something?
No.
She said, what?
No. But I gotta tell you though, our CEO, I mean, she just blazes, so we have to just be paying attention, because her train is leaving, and it's a bullet train.
It is a force of nature. Yes.
Yeah, it really is. So yeah, and we're Kara and myself, we're excited about it. We're excited about it because we know how many more people we're going to be able to reach because of this. And it is going to be a game changer for sure, that we're doing the SIP program with CMS, and we have access to this amazing platform with Acclivity Health. So anyway, we look forward to seeing everybody along the trail as we go.
Hope, I just want to say thank you to Lonnie and Kara for representing Hawaii Care Choices so well. I appreciate them. I appreciate their leaning in and being on our rapid bullet train. They do a fabulous job.
You've got great people, Brenda.
Oh, this is, yes.
Do you want to add anything, Brenda? I know you've worked on this for so many years. Congratulations that all of this comes together. I love that Lonnie says, no, everything works well, but I know it's been many years of just trying to, because the system is not set up to make palliative care happen. So kudos to you guys and you for not giving up.
I'm actually by myself. I could take my mask off now. There we go. Hey, so, I think many of you have been on this train with me that are in this room. So everyone knows the challenges. I mean, Ray Sykes almost single-handedly, her and Robert Eubanks got supportive care out of HMSA, and that was just that changed the environment. UHA and their concurrent care program. We've tried every model. Our first model was called Hawaii Palliative Care Center. We hired a full-time palliative care physician, a PRN. That didn't work very well. And then we tried just doing consultations in the hospital. That didn't work real well. So now we have our community-based comprehensive, also known as ambulatory care. I think just persistent. The physicians the community doesn't know what palliative care is. They haven't embraced how that will change their lives. And, so grateful to Daniel Fishberg and everyone in Oahu that has been able to get palliative care in the acute care centers in Oahu anyway. And we're trying to get more services in the hospital. So it's just just keep going and pray that somebody gives you some money to help you along the way, because it's not really well reimbursed. So yeah, it's good though. I mean, we've just been so blessed. And again, look at the amazing people I have to work with. So
I did forget to ask if the VA, you're also able to partner with the VA with their new program.
yes, we do. And so we have concurrent care / supportive care with HMSA, UHA, Medicaid with the Quest program, the children, and then the pilot project we have, and then the newest one is the VA, working with concurrent care. You know, our palliative care census today, I just heard that by tomorrow, which is Friday, we'll be at 61 patients in our palliative care program, and our hospice program averages around 120.
And that's an increase, right, Brenda?
Yeah, prior to about mid 2019, our census started going up in the hospice. We historically have never arranged over 80 patients average daily census. So we've had significant growth. Part of that's related to all of the initiatives that we've worked on for so many years, and that just finally started working. And then people like Kara and Lonnie being out there in our community and our liaison program. And then the pandemic definitely, people don't want to be in the hospital. And so that helped us be able to connect with them to provide them services in their home.
You guys really have done such a great job of pulling together. You know, we talk about a continuum of care and the different services, medical services and supportive services that are going to help people. And you guys really have done a great job of doing that. So thank you very much. Thank you for sharing.